So I'm going to actually ask Rebekah Edwards to come up, and so you'll have to correct me if I'm saying this wrong. I actually had to ask Kathy, but is it a doctorate of nursing practice? Is that how you would say that? So not a doctorate of nurse practitioner. So
doctorate of nursing practice.
Okay, so I mean that's you don't see many people, and I'm always impressed by that. So Rebekah is actually at St. Joseph's Hospital in Phoenix at the Norton Thoracic Institute, and her focus is really on ILD, and she's also the pulmonary program manager for the transplant program. I think St. Joe's is maybe not one of the busiest transplant centers in the country. Yes, so I think we really have a great opportunity with Rebekah. Just curious, all of you here, how many of you are at transplant centers, lung transplant centers? Wow, awesome. So that's great. So Rebekah is going to cover kind of all the issues around getting patients transplanted, which is going to be great. Thank you.
Thank you. All right. Well, it's really an honor to be here, and just it's such a great thing we've had so far, having this nursing and allied health tract, and it's great to be a part of it. So my practice is actually mostly interstitial lung disease, but the way that the clinics are set up at St. Joseph's is that we share kind of a roof with our lung transplant program, which stays pretty busy. So by the nature of my work, working with patients who have advanced lung disease, who have fibrotic lung disease, I've kind of developed a lot of knowledge and special interest in transplant. So we'll talk a lot about the guidelines for getting our patients into transplant, and then I also want to focus a little bit on how we overcome some barriers for patients who would like to be transplant candidates, but maybe have some things standing in their way. Because I think that's an area that we as nurses and other members of the team, we can really make a difference there. So we'll get started. These are our goals. So we'll review the guidelines from the International Society of Heart and Lung Transplant. And along sprinkled in there, we'll talk about what the guidelines are and then maybe where we are right now in the current literature, looking at how we're referring patients to transplant. And then we'll review absolute and relative contraindications for transplant with kind of a focus on what we can do early on in their disease course to help modify maybe some things that could stand in their way if they're really desiring to go that way towards transplant. And then we'll review the components briefly of a lung transplant evaluation. Certainly we could spend a long time on that, but we will go through that and then review strategies for talking about transplant and transplant eligibility with our patients. So to just kind of set the table for this discussion, what is the main rule of who should actually be referred for a lung transplant evaluation? And really, disease aside, it's any patient who has a chronic lung disease who has a more than 50% risk of death in the 2 years coming up. Along with patients being strong enough to have about an 80% chance of surviving the first 90 days post-transplant, so that surgical period, and then presuming all goes well with their new lungs, could survive 5 years after their transplant. So when we're talking about patients who have fibrotic lung disease, and specifically IPF comes to mind, definitely this is going to be something that we encounter every day in our clinics, is patients who have a year, 2 years left ahead of them, so these conversations become common. I put this slide up here, and I think we've seen it before today, but it's just a reminder that in spite of all of the exciting progress that we've seen, we still have to talk to our patients about a really serious natural history of their disease. We don't have a great way of stratifying which ones of our IPF patients are going to be rapid progressors and those who might stay still and stable for a while. So this is still what's walking into our clinics every day. And then just a reminder that in addition to our IPF patients, really a lot of our other diagnoses, even though they might have more therapeutic options available to them, they're still looking at a pretty grave prognosis. And this just highlights patients who have connective tissue disease and also have that same UIP pattern. And end of the day, things look pretty close side by side on how these patients are expected to do. So we know that the diagnoses we have, we're probably going to be talking about transplant. So this is just some preliminary data that I pulled looking at how are patients being referred to transplant. So meaning they're not being listed, they're just being referred for their initial talk. And there was one registry, it's called IPF Pro. Some of you all might be familiar with it. And it's a registry that enrolled IPF patients and then has now been expanded. But they pulled their data of patients with IPF who were eligible to be referred for transplant, and only about 23% of patients were actually referred in that cohort. I was surprised by that number. University of Chicago, they pulled some data from their center mixed in with CF patients, and the referral rate for their pulmonary fibrosis patients was about 60-some%, so a little bit higher. But interestingly, patients often had a big delay from when they were eligible for transplant to the time that they actually made it to a transplant center. Pardon me. And that could be up to 17 months, actually. And there really wasn't any documentation around why that remaining 40% of patients didn't get referred to transplant. So anybody who's looked at the the criteria for referring to a transplant center, I think we all wish patients would walk into our ILD clinic at this point. So really, you qualify to be referred if you have a usual interstitial pneumonia pattern, if you have a fibrotic, not a fibrosis, fibrotic nonspecific interstitial pneumonia pattern, and if your FVC is less than 80%, really you should be referred. So I wish all the patients in my ILD clinic came with FVCs of 90%. That would be amazing. So that also goes along with patients if they have any functional limitation, if they have any oxygen requirement. Every single one of those patients actually meets criteria to at least start a conversation about transplant. So I think part of it is that maybe we see patients a little bit later than we would like to. And then patients often come with comorbidities, and we'll dig more into that later, but that can be something that sometimes blocks patients. Sorry. Okay. And then in contrast to timing for referral, there's the timing of listing. And so the idea is that patients should be worked up at the time that they're meeting any of the criteria on the previous screen. And then they should be listed if they're having a significant decline in forced vital capacity. People usually will say 10% or greater of a drop in 6 months, but really there's some data suggesting maybe 5%. We should start looking a little bit closer. If you've got a decline in diffusing capacity, if you're desaturating or dropping how far you can walk on your 6-minute walk test. And then certainly if we're starting to pick up on pulmonary hypertension, whether that's on heart cath or whether it's on echo, that's a poor prognostic indicator, and that's the point at which patients might be ready to be listed for transplant. So it seems like we have a little bit of a gap between when the transplant center would like to start working up the patient because of their unpredictable course and when we're actually able to get patients there. Interestingly, there was some data published from the PFF registry, and they didn't look actually at referral to transplant. They looked at listing of transplant patients. So they pulled IPF patients who met criteria actually for the listing to be actively looking for an organ, and they found that only 36 of 500 and something patients were listed. So strangely, we have a big gap here. Okay. So connective tissue disease, they fall into a little bit different category in terms of when they should be referred. So what the ISHLT guidelines recommend is that these patients do get at least a trial of some sort of anti-inflammatory medication, whether that's your mycophenolate or whatever's appropriate for that patient. And then the one disease that I will highlight is scleroderma. As many of you guys are at transplant centers, it varies a lot whether or not people want to transplant or even take a look at scleroderma patients. And we've had some great data presented about reflux, and really that's the main issue with patients who have scleroderma is we often have these absence of motility in their esophagus, really predisposing them for aspiration, which is a concern for organ rejection. So those are patients you may want to start your conversation a little bit earlier with them, and they may need to see multiple centers. Okay. So we talked about all the reasons why patients could be transplant candidates. And then here's kind of a general overview of reasons why patients may not meet criteria. So these are absolute contraindications. First is a recent history of malignancy, and it varies a little bit, cancer to cancer, and even center to center. So things like basal cell cancers, squamous cell cancers that patients have caught early, typically those don't count too much against your patient, but if they recently had like a colon cancer, or a melanoma, those are your more serious cancers. Those are harder to overcome. And I think when we're talking about helping our patients early on in the game so that they won't run into so many issues if and when they choose to pursue Transplant, I think this is one of the ones specifically with skin cancer that I try to work around. So when my patients get a prescription for mycophenolate, it comes along with a referral to dermatology so that they start getting their screenings every single year. And if they're gonna have cancer or skin cancer, we're catching it early. And reminding our patients that, we're all focused on your lungs, but guess what? You still have every other organ, and we need to do your routine health screenings, catch cancers early. So another absolute contraindication would be untreatable significant dysfunction of another major organ system. So we're thinking about like kidney failure, heart failure, that kind of thing. And uncorrected atherosclerotic disease. So we just had a great presentation about the risk factors, or that IPF patients are more predisposed to coronary artery disease. And actually, oftentimes we get CT scans that note coronary artery disease, and that actually correlates very well to what's actually going on in your patient's body. So referrals to cardiology if we need to. This is another reason why the early referral to a transplant center is important. I've had many patients who we referred, and they ended up needing a stent placed. And if they got the stent, great, they were good to go, but do they have 6 months to be on Plavix? So we have to think about that. Medical instability, so that argues against we don't want really, really sick patients who might not make it through surgery. Class 1 or 2 obesity, this is one we work through all the time. And I've made best friends with our medically supervised weight loss doc, who is wonderful. But dealing with that early on in the game, and often patients lose weight and we improve their functional status anyway, it's great. The one other thing that I will throw in here is substance abuse, and that often includes marijuana, even if it's legal in the state that you're in. So keep that in mind. And then nicotine, of course, is the most common one. So patients need to have quit smoking for at least 6 months prior to being seen in a transplant center. And what we often miss or forget to tell patients is that includes all nicotine products. So last week, I had a patient, and we were kind of like on the border. Are you going to go to transplant clinic? Are you not? We thought, if you're worse, the next time you come to clinic, we're going to send you. So I walk in the room, and he goes, Rebekah, you are going to be so proud of me, because he'd quit smoking about a year ago. I got so stressed out. I saw the cigarettes at the store. I didn't buy them. I bought the nicotine gum. And I said, oh, I'm so glad you didn't smoke, but that gum's a problem too, darn it. We'll try again next time. So counsel patients around that, because oftentimes I forget to ask, and patients are taking nicotine products in the long term. Relative contraindications. So these are ones that may vary center to center if they're willing to accept these patients. Age has become a real relative contraindication, depending a lot more on the person and their health. Malnutrition, severe osteoporosis, especially when we have patients we're treating long-term with prednisone. I just really am an advocate of getting a DEXA early and treating patients before we get to this problem. And then medical conditions that have not resulted in end-stage organ damage, and I think this was covered really well by our previous discussion. The other caveat I'll add here is that patients who want a transplant, they need to have a caregiver. And in fact, I have one patient, and his only barrier is that he doesn't have anyone who will be his caregiver. So this is another thing that we, as nurses, as people who have time to spend with patients, we can vet out, is who they have in their life who might be willing to devote that kind of time to them. And it's a big commitment, and it's a big, quite frankly, burden, because the person goes with them for every single thing. So they'll need a primary caregiver and a secondary caregiver. Okay, we kind of went through which ones can be modified. Okay, so what does a transplant workup include? So this is kind of the beginning list. Patients can expect to go through at least all of this, and a very important piece of it is actually the financial consultation, because post-transplant medications, I mean, we struggle getting our patients to afford mycophenolate, and they're on a bunch of things post-transplant. So patients will have a meeting with a financial counselor, and oftentimes they need to wait until open enrollment to change their insurance. So that's something to keep in mind as well. So once your patient's gone through their whole eval, they get presented to a multidisciplinary review board. And there's really 3 possible outcomes that can come from the review board. 1 is yes, you're good to go, you get to be a transplant candidate, and then they go on to listing. 2 is maybe. We think you could be a candidate, but we need to know more about this area of stenosis in your lung, about your esophagus, and patients can end up going down a whole nother rabbit trail of tests and consults and that kind of thing. Again, taking time. And then finally, no, patients aren't denied for transplant at that particular center. And I think the thing to remind our patients is that they do have every right to get multiple consults at different centers. In fact, they can do so simultaneously and can in fact be listed at more than one center. And a lot of patients aren't aware of that. Okay, so once you're ready to be listed, we move forward with the lung allocation score. And so this is a complex series of calculations. They post all the calculations in case you want to have fun calculating them yourself. But typically what's done is you log into the website, enter all the data from the patient's workup, and like one of my colleagues says, it's like TurboTax for lung transplant. It like puts in all the numbers and then spits out what your score is. And that's what you are. So it's 0 to 100, and the higher your number, the higher on the list you are, if you want to use that terminology. Patients kind of like that terminology. And you'll be the first person to get an offer on organs if they match you. And it's done within certain regions, which we have highlighted up here. Transplant outcomes. So nationally, the outcomes are 1 year is about 90% survival, 3 years about 70%. And 5 years is about 50%, and then we really don't have data after that. You know, we all know that one lung transplant patient who's like 15 years out, but we really don't have great data post that 5 years. The great thing is that every center is really transparent, so you can log into this website here, and you can look at every single center's outcomes, compare them against each other, compare them against the national average. Okay. So a few of my thoughts for talking about transplant with patients. I am a big advocate for bring it up early and don't be afraid to be the one who brings it up. I think us bringing up transplant and talking about that this disease is progressive, and I typically lump it in with talking about palliative care, which we're going to hear more about. I talk about all these kind of options that I want them to think about early. And what we really do is I think we end up handing the power back to the patient so that we're not waiting until, gosh, they've been lugging around 10 liters of oxygen to bring up the conversation. We bring it up when just a normal visit. They have time to read about it, think about it, talk to their family about it. It's a great option to be able to go for transplant. And in IPF, it does extend people's lives. There's papers that have been published talking about that. But it is kind of like switching one disease for another disease, and patients have to decide for themselves if it's something that they want to do. I think even going early to have a consult with a transplant group is really helpful for patients. What I do a lot is I send patients to our lung transplant support group, which we're fortunate to have right there where I work. And I've had patients come back and say, yeah, that's definitely for me, I'm so excited. And I've had patients come back and go, yeah, I don't think that was for me, thank you so much for teaching me about it. So I feel like that's probably a good indicator that they're learning a lot from people who are in their same shoes. And then I will say, I can't highlight enough, I think, the role of us as nurses, as pharmacists, as social workers in educating patients. One of my favorite patients I've ever had, he kind of like didn't want to talk with anyone about anything when we first saw him early in his course. I brought up transplant at one of his visits, and he's like, well, I just don't talk about that. I said, okay, well, we don't have to talk about it today, but at some point you just need to let me know if that's a closed door, if you want to talk about it, just so I know I've served you well. Because I'm your advocate here, and my job is to make sure that you know everything you need to know about your options. He didn't like it that day. The next day he asked me questions, or the next visit he asked me questions about it. And to my shock and surprise, he actually decided he wanted to be a transplant candidate. So he did his whole workup, came back to my ILD clinic, and we watched him for a good year, and he did okay. And then out of nowhere, he had a flare, and we had all of his workup in line, so he was able to get transplanted, came back to see me in my office and said, you know what, we're so thankful, but we really appreciate you taking the time to educate us. And we're so grateful, you know, we're going to spend our time leading IPF support groups and giving back to the local IPF community. And I don't say that to say, oh, we need to push all our patients towards transplant. And I don't say that to say, oh, you know, this is how it should be done. But I do say it just to highlight that I think we all have really unique roles here. And I think the ability to take time to educate patients is just huge. So if you're already talking to your patients about transplant, about their options, I think that's so great. And if not, maybe it's something to consider adding to your education list. So thank you.